the Division of Health Systems and Public Health. Welcome to our today's webinar, which is hosted by our division. And our presenter today will be Vishar Brijla. Vishar will be presenting on understanding the concerns and challenges against the NIH Act. So, as we all know, that the bill was signed into law in May, and since then there have been a lot of questions, discussions in the corridors, and even in the boardrooms, I would say so. And today we are going to, focus on what are the concerns, how do we understand the concerns, etc. Before going further, let me just give you a brief description of Visha, our today's presenter. He's an economist who specializes in health policy, health financing, and economics, as well as public-private partnerships and health insurance. And he has got more than 25 years of experience in advising national governments across 11 countries. Currently, Vishar is working at NHI, Clinton Health Access Initiative. And at NHI, he has served as a country director for India, regional director for Southern Africa, as well as a country director for South Africa. During his time in India, Vishar was very instrumental in the introduction of a unique pediatric art program, which was done through partnerships. And Vishar has also been on various ministerial committees, including the ministerial appeal committees, ministerial task team, district financing, public-private partnerships, etc. And in April 2014, he was appointed to the task team to investigate the restructuring of NHLS. I hope you'll be talking to so many of these stories through his presentation. And and in November 2014, the minister appointed him to be the interim management team for NHLS service. In December 2015, he was appointed as a lead workstream for the future of medical schemes as part of the 6 NHI work streams by the minister. And in May 2016, he was appointed to be the NHI national coordinator. So you can see that he has had a lot of exposure to this NHI, story, and I think he's here to share with us the process we went through, as well as that now it's an act, the challenges and concerns that we may have. So without taking not much time, let me welcome Vishar to the podium. You are welcome. Yeah.
Good afternoon, everyone. Presentation.
Oh, sorry. Sorry,
Okay,
let's stop sharing and then start sharing.
Oh yeah, did you guys manage it? Right.
Yeah, I think we figured it out.
Okay.
Here, let's see. We're trying to project the presentation.
Okay, so
that he sees it, because it looks like it's projected on the screen. But
okay, so what I always normally do is show you the screen. So the moment you do that,
apologies, we are being assisted by IT. Apologies, we've got a technical glitch and the IT is helping us. Thanks.
Should I unmute the camera? Okay.
Okay. Thank you so much. Hello. Hi. And where do I mute? Unmute. I don't want to tamper and then.
No, please unmute. Please.
Okay. All right. Okay. Cool.
Just okay. Let's make sure that they can hear you, but I'm sure they
Then go
can.
back to the. Okay. Thank you very much. Yeah. Thanks and apologies for that. Let me quickly just hand over to Vishay. Over to you, Vishay.
Good afternoon, everyone. I hope you can see the screen for those of you that are online, and I hope that I'm audible as well. So, the idea of the presentation today is to walk through some of the issues, concerns, and to try and understand what significance they are, of what significance they are. Why are people making so much of noise about them, and what are potential ways in which this can be actually overcome. So if we start and look at the roadmap for UHC in South Africa, now some of this started before the 1993, but let's start from 1993. So 1993 was the ANC Health Plan was published. In 1996, we had the white paper on the transformation of the health system. In 1998, we had the Medical Schemes Act as well as the Medicines Act. And in 2003, the National Health Act was passed. In 2011, we had the Green Paper on National Health Insurance that was published. In 2017, the White Paper, as approved by Cabinet, was published. In 2019, the NHI bill was introduced into Parliament. And earlier this year in May, the President signed the NHI Act into law. So as you can see, it's not it's been a long path. It's been a long process of debate, discussion, and consultation. There's been a many occasions when the policy framework has been amended, adjusted, and it's been seen as a living process. Now, as Juliet mentioned, right, the act has been passed. So what? What does that actually mean? What happens next? So in terms of Section 59 of the Act, it says that the Act, called the National Health Insurance Act of 2023, takes effect on the date fixed by the President by proclamation in the Government Gazette. So as it stands, even though the NHI Act has been signed into law, it has not been given effect yet because the proclamation has not been signed by the President. Now, how long does it take for proclamation to come into effect? Typically, it could take a few days. a few weeks rather, or 2 months, 2 years. In the case of the South African Constitution, it took 2 weeks, a few weeks. In the case of the National Public Health Institution of South Africa, it was passed in 2019. It was assented to by the president in July 2020. It still has not been promulgated. So we don't know as long as how this can take. What we do know is that legislation can also come into effect where certain sections of the Act are not made operational and certain sections are never promulgated. So for example, in the National Health Act, the certificate of need provisions was not promulgated for 21 years. And the international benchmarking within the Medicines Act has not been promulgated till today. So why and what's the difference? So typically what happens is that in this case, the Department of Health minister will have to provide a report to the president to show that they have a capacity that can implement the system. They've got systems in place to implement the act, and they have regulations that have been drafted to give effect to certain sections of the act. So again, we see that there was the bill was signed, there was public consultation, both at National Assembly level as well as the provinces. It was deliberated upon by Parliament, certified by state law advisors. So what is the problem? Why do we still have a debate? So some of the different positions that have been put across, and again, I want to emphasize that these are comments and positions that organizations, people, entities have put forward, is that even though there's been consultation for the better part of 1.5 decades, they feel that their comments have not been incorporated or addressed. Now, I've put this little thing up there that says it's about the money, and I'll explain why I mean that by that as we go through this presentation. But it does come down to the money. So the current issues with the Act are there have been several references made to the nature of the opposition to the Act. As I mentioned, we've been discussing it since 2008. There have been issues around what's been called fearmongers. The key issue that's been raised by those that have opposed the Act is that government has not addressed their comments. Now, consultation does not always equal incorporation of your comments. However, what we need to focus on is, are people focusing on the wrong issues? And what exactly is the areas they should focus? The Act itself is not the difficult part. It's what happens after that. What happens now that the Act is signed? What is ready to be implemented? And when is NHI fully implemented? These are clauses and terms used in the NHI Act. When does implementation start? And this is a critical one because as we are seeing right now, there are legal challenges to the Act. So we don't know whether that's going to delay the implementation. And what do all the transitional arrangements mean? And the Minister of Health has indicated that he is undertaking a series of roadshows across the 9 provinces to unpack some of the transitional arrangements that will be taken forward. Now, when we look at the current situation as far as the NHI Act is concerned, as far as universal health coverage is concerned, I think we must take a step back to understand what is the key policy objective of these reforms. So what problem were we trying to solve, and what were we trying to get out of that? So in the white paper on NHI in paragraph 28, it says that the South Africa's considered approach towards achieving UHC will be through the implementation of NHI. The conceptualization and design of NHI will take into account the country's experiences and global lessons learned in the development of systems for UHC. Now, there's also in paragraph 29, an articulation of what does NHI actually mean. However, if universal health coverage is the goal, then we need to focus on what are the issues that help to achieve this goal and what are the things that need to be removed or added that will improve access, quality, and affordability. That's ultimately what we're trying to achieve. Now, when when we look at things like the NHI Act, NHI Fund, role of medical schemes, it's a perfect example of what I call distractions. The issue around the role of medical schemes in terms of whether it affects affordability and quality or access, if the medical schemes are too expensive, if cover is too expensive, if it limits access, if it does not address the needs of people, then changing financing flows through an NHI system does not deal with those factors. We should deal with those factors through the Medical Schemes Act, and I'll explain how we can do that later. So, what are the issues? Some of the issues that have been raised are directly related to what's said in the Act, mainly around differences of opinions, and differences of opinions don't necessarily mean that people disagree or are opposed to each other. It might mean that they don't understand each other from where they're coming from. Dialogues and discussions should be removed from emotion and be factual and correct. And we need to debunk myths and incorrect statements in both what has been reflected by government, but also what has been reflected by the private sector. And we must be cognizant of the fact that there's been poor communication on both sides in terms of how and what the issues are. What is clear, though, is that the idea is not, in this presentation at least, not to criticize government, but to demonstrate what needs to happen, to demonstrate the complexity of the issues and the design needs. However, it is important to correctly contextualize the arguments and debates and not perpetuate incorrect statements and interpretations. So, in my view, all of the debates can be narrowed down to 6 core elements or areas. These include governance, leadership, including the issues around corruption, provider payment mechanisms, accreditation and contracting of professionals, benefit design, including entitlement versus affordability, role of medical schemes, and the role of provinces. Now, all of these issues are not particularly difficult to resolve. However, it does require commitment from both sides. And a good example of having clear commitment on it was that when President Mandela was able to negotiate freedom, democratic freedom in South Africa, he didn't negotiate with himself. He had a willing person across the table to negotiate with. So both sides need to be willing to compromise, to understand each other, and to be able to have meaningful discussions. And it's all about the money. So here's a clear example of why people are concerned. It's been raised several times in the public comments that have been made to the Portfolio Committee. It's been raised since the Portfolio Committee deliberations have taken place. Section 49 of the NHI bill, well now Act, says NHI will be funded from the reallocation of funding for medical schemes tax credit, general tax revenue, a payroll tax, and surcharge on personal income tax. It also includes the reallocation of medical scheme tax credits. And there's been widespread support for the reallocation of medical tax credits. A typical, rather a quotation from one of the groups that presented to the Portfolio Committee on Health, NHI, they said that as part of the funding for NHI, government should completely end tax rebates to medical scheme holders Furthermore, government should redirect tax rebates towards the NHI fund. Now, it's all about the money, right? So there are different estimations of how much this is going to cost and what it actually requires. Speculating about the actual quantum, I don't think actually gets us forward. But if you look at the context of the amount that needs to be raised versus what is actually being there in terms of tax credits, we can see there's still a significant sum that needs to be rediverted. So what are the relevant issues that to influence implementation? As economists, we like to do the wonderful thing of changing definitions to suit our targets. So we keep changing the definition of unemployment to mask the true effect. But unemployment is a serious issue. Unemployment does underline certain social ills, crime. It also it also deals with issues around tax evasion. Unemployment has perpetuated, and South Africa having one of the most unequal societies in terms of income levels, we also see that there's a social impact. The higher the unemployment rate is, the greater the dependence is on social assistance, social grants, and the ability to fund government services is constrained. And I'll show that just now. But basically, it means that fewer people in the formal sector employment are having to carry a greater tax burden. Now, there are other factors that are critically important. We've heard about, well, we don't have the right GDP growth rate to be able to start this reform. We've seen that issues around budget cuts, especially in the public sector, has been used as reasons or explanations as to why it's not ready or time to implement NHI. We've also seen and understand that there are leadership and governance issues, including the different institutional relationships, again, being used as reasons why we can't start. And then health service improvement, quality and access. Regardless of whether it was Minister Motsoaledi during 2010 and 2019, whether it was Minister Mkhize, whether it was Minister Pahla, whether it's Minister Motsoaledi again, the comment has always been, leave the private sector alone, go fix the public sector. We do need to deal with issues around health service improvement, quality and access. Now, this graph is something that comes from Stats SA. What is important to note in this slide is the level at which we've declined in terms of employment. So the bottom blue bar on the graph represents formal sector employment, well, formal sector non-agriculture employment. And as you'll see that between January 2008 versus October 2021, we have in absolute numbers fewer people that are employed. So over the span of 13 years, regardless of the size of the increase in the workforce, we have fewer people in formal sector employment. Now, why is formal sector employment important? Is because those are the people that are taxed and pay taxes, which means then that despite the issues around inflation and increased government expenditure and other contributing factors to inflation, a fewer number of people are expected to contribute to an increasing government revenue collection target. And that's why employment and unemployment is actually quite a critical factor. Now, economic growth and the access to increased revenue is an important issue. As I mentioned, employment levels are critical. There's been some analysis that shows that South Africa is actually an outlier. In typical macroeconomic theory, will tell you that over the long run, as your GDP levels increase, employment will increase. As investment increases, employment increases. However, in our case, we've been going the other way around. So even though there's been a marginal increase in GDP, we've actually been declining in terms of employment levels. Now, if you go back to the slide previously, where we estimated anything between 180 to 200 billion is required for funding NHI. If you do a straight line calculation, it's a 27% increase in personal income tax. Now, it does not mean that that's government policy and that's the way it's going to be. Thank you. But it is about the money, and I think we need to find ways of finding a smoother transition. Budget cuts. We've seen that over the last year or two, and then going forward, that there is a shrinkage in terms of the public health sector budget. And the main argument for this is growth in government expenditure combined with poor growth outcomes. So if you look at our per capita income levels, again, over the period 2008 to 2022, you'll see that there have been periods where we've had significant decline, and our levels have not lived up to anywhere where Treasury has forecast between the 3 to 4% GDP growth levels. In the long run, low economic growth has materially stunted the economy, created fewer jobs. As I mentioned, Stats SA report shows fewer number of people employed. What does this mean? And since 2009, we've seen expenditures outstrip revenue, resulting in the growth of debt. Now, we've actually increased to almost 75% of GDP. The graph on the left shows the percentage of GDP and the growth in terms of our loans. And the graph on the right shows the difference between expenditure and revenue. And you can see that between 1999, 2000, up until 2007-8, we were on par. Revenue matched expenditure. However, since then, there's been a significant shift. And that shift is compounded every year as we go forward, which results in one of two things. Either you reduce services or you borrow more money. Guess what we've been doing? We've been borrowing more money. So if you look at 2023, 2024, debt servicing costs was 356 billion rands. Public health spending was 267 billion. In 2024, that is expected to increase from 356 to 382, whereas health goes from 267 to 271. Right. So debt is growing faster than our spending on health. It doesn't get any better as we go through the years. And by the time we get to 2026, 2027, debt servicing costs actually outstrip social development expenditure as well, not just health. So we can't continue on the trajectory that we are in by continuing to borrow money. And again, this is not an NHI issue. This is a Treasury issue about our economy. However, it does have impacts in terms of what can and can't be done. This is just a explanation of some of the different factors. We've seen in different settings that training and retention of health professionals has been problematic, and certain positions, especially registrar positions, have been reduced. We've not been able to retain community service doctors post their community service term. But we must understand that the impact of budget cuts is not just on health, but also affects education and social development. And as much as it affects higher education, it affects the amount of money that our tertiary institutions have to train health professionals. So whether they are subsidized partly by health or by higher education, both sectors are getting less money. So about the money, there was all the issues about money. These are some of the issues that have been raised around the governance of the fund. that the minister has too much of power, or too much of power rests in the minister. Um, the 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 concentration of power um, and the lack of separation between functions puts the system in a situation that can be easily manipulated. There have been calls for reporting and accountability to shift from the Minister of Health to Parliament. However, the shifting of accountability to Parliament is particularly problematic and actually cannot happen. Um, by definition, the NHI Act, the NHI Fund in terms of the NHI Act, is a Schedule 3 public entity. And in terms of the PFMA, that is governed by an executive authority. That executive authority is the Minister of Health. So if you want to change the responsibility of the Minister of Health, you've got to change the PFMA and the reporting structures around such something. So it's not a simple area of change. However, if we accept that certain things can happen and we make things more transparent, it's different. Now, one of the comments made by one of the portfolio committee members against criticisms of the NHI bill at the time in Parliament was that political parties publish their policy goals and objectives in their manifestos. They campaign for support, and based on these manifestos, the Constitution gives them democratically elected parties the right to pass legislation they deem necessary and to appoint people to certain roles in government to advance those policy goals. That is the system on which our democracy is based on. Now, we also need to understand that there are also checks and balances in place to guard against this. And in terms of this, we have Section 2 and Section 44 of the Constitution that state that in exercising its legislative authority, Parliament must act in accordance with and within the limits of the Constitution. And the Constitution is the supreme governing legislation in the country. Section 167 of the Constitution also confers jurisdiction to the Constitutional Court to decide on the constitutionality of any parliamentary or provincial bill or legislation, which means that the judiciary has an obligation to test whether any law that's passed is compliant with the Constitution. And that's to some extent that the checks and balances in place. If we accept that the fund and the board has to account to the minister, then what do we actually do? Find a way in which certain things can be made more transparent. We can find ways in which nominations and appointments and interviews and selection processes are open to public scrutiny so that we don't see abuse of power taking place. The issue around corruption, fraud, and wastage, and I think there's a particularly difficult issue that we need to understand. The issue around corruption, fraud, and waste tends to be more biased towards the provider side than the actual purchaser or the funder side. We see that currently within the medical schemes environment. We see that in terms of the relationship between national treasury, national departments of health with provincial departments of health. It's a difficult and but important issue that needs to be dealt with. We need to hold people accountable. For example, and I apologize for singling provinces out, but if a province is inefficient in the way in which it manages its finances, wastes resources due to mismanagement, corruption, it limits the amount of money they have available to deliver services. And if this is going to be a reimbursement type of structure where a purchaser provider is created, then having less money to deliver services puts you in a much more difficult position from a provider perspective. And it's all about the money game. There have been significant comments made around the legal and constitutional issues related to the bill. When the comments were being made to the Parliamentary Portfolio Committee on Health, a a lot of people, organizations, entities that went before the committee, just over 2/3 of them said that they were concerned about legal and constitutional issues. 27% were silent, and 3% said they were not interested. However, when the court has to decide on whether the NHI Act is constitutional or not, or any provisions in the Act is constitutional, it has to be done within the confines of the Constitution. Chapter 2, the Bill of Rights of the Constitution, sets out the rights to which people in the country are entitled to, and that the state is required to respect, protect, promote, and fulfill. Now, the Constitution does allow for these rights to be limited, but only if there are grounds for that limitation. Now, we saw during COVID that there was not just a public health need, but a broader need for actually rights to be limited. Hence, lockdown was imposed. Now, if you do limit rights, the state must show that they have complied with certain requirements. One is the nature of the right. The second one is the importance of the purpose of the limitation, the nature and extent of the limitation, the relationship between limitation and its purpose, and whether there are any less restrictive means to achieve the purpose. Now, if you look at those 5 elements, the process around consultation, deliberations, and the passing of the NHI Act shows that government has made an attempt to deal with each one of those areas. Whether it is adequate or not is probably best for court to decide, but to limit rights, which the NHI Act proposes in the initial phases, they've met the requirements that show that. There are some other issues that influence the approach to implementation, and they are particularly important. The first one is the role of the province, including district health management teams, and something called the contracting units for primary healthcare. These are important for different parts of discussions. The role of provinces impacts on the issues around joint appointments, especially in academic facilities, the training of health professionals and the sustainability of training programs. So, for example, let's say that a particular academic hospital is not accredited because they don't meet all the standards to be a provider under NHI. How are we going to continue to sustain the training of our professionals if that's an uncredited institution? Now, the white paper on NHI sets out establishment of 2 important committees, the Tertiary Services Committee and the Human Resources Committee. Now, technically, these fall outside of the scope of the bill or the act. However, they are important because they could potentially serve as structures that could facilitate the transition. I think that there's another issue that complicates life, is what we think we know about different things. So NHI does not equal the NHI bill or NHI Act, and it does not equal UHC. These are not interchangeable terms. They actually mean very different things. And it's important for us to understand those differences. The relationship between academic hospitals, medical schools, and provinces versus NHI is also critically important. The reason why I say this is because if you design benefit packaging structures in a particular way, with a focus towards primary health care, then is our training platform, nurses, doctors, being aligned to that service benefit structure? Or are we just training as per normal? So there needs to be a compliance. We also need to understand that training of specialized services, super specialist services, is something that needs to continue and maybe needs to be removed from the equation.
I'm sorry to disturb, but we can't hear online. The speaker seems to be muted.
Can you hear now?
Yes, thank you, Dr. Nisulu.
Okay, thanks.
Can everyone see the screen as well?
Yes, thank you.
Do you want me to go back? How far back do I need to go?
I think the previous slide, perhaps.
Okay, so what I was referring to in this section was what are some of the issues relating to implementation that are important for discussions, but should not necessarily influence the implementation of NHI. There are certain areas around training, especially, and the relationship between the province, training institutions, as well as the NHI fund that must be examined. And I think the second last point, which is also something that needs to be clearly understood, is that sometimes we tend to use terminology interchangeably, but they do not mean the same thing. NHI does not equal the NHI bill or the NHI Act, and NHI Act does not equal UHC. They are different objectives with different definitions, and they have served different purposes. In terms of a single payer, single purchaser model, this was the biggest concern raised by the private sector and possibly remains the biggest concern raised by the private sector, or being raised by the private sector. Now, one of the reasons for this, especially from a funder's perspective, challenges with the Medical Schemes Act, or medical schemes rather, and this is a reflection of what has been said, and it also reflects on the questions that were asked by the Parliamentary Portfolio Committee members, two different people that came to present to it. The first one is that benefits tend to run out in mid-year. The benefits covered by medical schemes are not comprehensive. They're resulting in members having to make substantial out-of-pocket payments. There are situations where the medical scheme only covers part of the cost. And then there are services that the medical scheme doesn't cover at all. The second one is that medical scheme cover is too expensive. The current environment of prescribed minimum benefits has contributed to the rising cost in the private sector. And this stems primarily from the clause that says medical schemes must provide PMBs at cost. There are way too many options, making it very difficult for members to choose what option to be on. Some schemes have got 5, 6, up to 16 to 20 different options. And none of those options are consistent. They vary in part in some way or the other, which again is the reason why it makes it difficult for people to choose and to also know what they have in terms of cover. The Medical Schemes Act also says that each option must be self-standing and self-sustaining, which means we're fragmenting the risk pool further within a medical scheme. There's also the concern around service discrimination based on ability to pay or income, and then the issues around high administrative or non-healthcare costs. So I think it's important at the same time to understand what is the business of a medical scheme and what does payment in full mean? Now, when PMBs were introduced, prescribed minimum benefits were introduced, the pay in full provision wasn't a risk for the medical schemes, mainly because healthcare tariffs were collectively negotiated between schemes and healthcare providers. Tariffs were published, a national reference price list was published, and professional associations published ethical rules around how much could be charged. However, claims that PMBs are not subject to benefit limits, but subject to co-payments have been introduced by schemes as a limitation measure. So what it basically means is you get told, sorry, you didn't go to a designated service provider, so we're not paying your thing in full, not claim in full. Or even if you go to a designated service provider, we're only paying X amount towards the claim, which then results in significant co-payments and balance billing. So if medical schemes must manage their claims and expenditure in the face of unregulated pricing, then there's pretty much no cap on the fees that can be charged by providers to medical schemes. It results in one of two things, right? It results in basically restricting benefits or making it more difficult to be classified as a PMB. And I speak from personal experience that it took me almost a year to have my cancer classified as a PMB. So when you put through a difficult process to be classified as a PMB or your condition to be considered, sometimes people just give up. It's not worth continuing. In my case, I personally, as well as the health professionals around me, refuse to give up on that part of it. One of the biggest problems that was created was the creation of DSPs. DSPs were not properly defined and regulated in terms of their practice and gave the schemes the ability to place limitations on PMBs, and therefore co-payments started to rise. Now, it's also that schemes have got complex rules. You phone a call center. If you're lucky, you'll get a human being on the other end of the call. You've got to navigate through different parts. You get told by a call center operative that your claim is not covered or your condition is not covered. No reference is made to a clinical review or anything like that. And that's not only the problem. It's a problem that also arises when you have to submit claims and question why it has not been paid. So during the portfolio committee hearings, the National Department of Health made specific comments in response to what was said about Clause 33, which is the role of medical schemes. I'm going to touch on the ones that are highlighted only. The Department of Health argued that Clause 33 is essential to achieving equity in access to the entire financial and non-financial, especially in the context of human resources of the national health system. They further said they'd like to emphasize that it will take a reasonable time for the NHI fund to establish an equilibrium and settle on the benefits that it will pay for. As benefits are fully paid for by the fund and providers are accredited to deliver those services, it will be inappropriate to have duplicate funding streams, and therefore only the fund will pay for those services inclusive. And medical schemes will pay for services that are not included. The implication of the provision is that fully implemented will be detailed in the Gazette by the Minister, and it will determine what the processes are. They also said that the department is of view that Clause 33 should remain generic as it's currently outlined, and this will allow significant regulatory provisions to be made to facilitate the implementation, and that the clause should not become a prescriptive one. Now, I want to explain what does that mean. The challenge that government is trying to achieve or overcome is an equity problem, but the way in which you can look at it is from a vertical equity and a horizontal equity perspective, where vertical equity is relating to the distribution of resources between the public and the private sector, and horizontal equity is looking at issues around geographic distribution, both in terms of finances, but also in terms of professionals and facilities. So it's not just about certain specialties being in the public sector, in the private sector. It's where they are in the private sector. So I think it's a challenging task that they need to overcome. The other issue that has come under scrutiny recently is the issue around certificate of need. And the question around horizontal equity, as I've termed it, is certificate of need the best way to do so? Huh? Some thoughts. Again, the thoughts, my opinions, they're not cast in stone. If you work off a system whereby PHC services are going to be provided on a capitation basis, and if you have a defined number of providers in a specific area, you also work out what is the minimum requirement for a general practitioner, for example, to serve to be economically viable. If you have an over concentration of providers serving a small number of people, you're going to have a smaller share of the revenue, because government is not going to change the rate of capitation just because there are too many people in a specific area. Which means that if you do want to maintain your revenue limits or levels, there will be a natural movement away from concentrated areas. The second area is around regulating of licensing of facilities. Now, instead of trying to deal with existing facilities, ensure that provisions are in place where licenses are provided for facilities in areas where you want them to be provided. Don't give a license to be provided in Cape Town, in the city of Cape Town. Give it outside. If it's in the case of Gauteng, there are more than 6 private hospitals, all within a 30-kilometer radius of each other. Does not make any sense. So if you're going to give a license, push it into an area where it's underserved, and then allow providers to be able to move there. The Medical Schemes Act, and I still go back to we shouldn't try and deal with the issues on medical schemes through the NHI process immediately. But the purpose of the Medical Schemes Amendment Bill in 2018, it was aimed to deal with the issues around legislative oversight of the medical schemes industry, the issues around aligning the regulatory environment within the changes of the sector, to improve the protection of medical scheme beneficiaries, and it was about alignment with the NHI fund at that stage. Right? The proposed changes were single benefits framework, reduce the number of options per scheme, reform PMBs in alignment to NHI service benefits, including common care protocols and pathways, regulate pricing. Right? High prices for health services, you need to regulate the pricing of services that are included in the comprehensive service benefit framework. One standard price for a reimbursement. If you're going to pay a GP a consultation fee, it must be the same regardless of whether it's a medical scheme or the NHI fund. And then the issue around differential pricing are based on diagnosis, and not to use diagnosis as a basis of differentiation. The issue around co-payments and balance billing to be removed, improvement in governance and non-healthcare, and the issues around reserves and solvency, and consolidation. So there are a number of different areas that the Medical Schemes Amendment Bill proposed that could still be of use in dealing with the medical schemes environment right now. If we consider that the full implementation of NHI could be anything between 5 to 10 years from now, you can't let the sector continue as is. The other thing that is very important to understand is that we have a growth of insurance products within the system. Now, the longer we take to deal with these issues, the more people are moving healthcare benefits and services outside of the medical schemes environment into the short-term insurance environment, where people have not necessarily full cover. In conclusion, we need UHC. Health service transformation, improvement in access and quality of healthcare is slowed down by different resource constraints. I don't think any of us have a different opinion on that. The impact of resource constraint, it filters through the entire system, including through social services. And I think the impending legal challenges, that should say to the Act, once promulgated, and the lack of practical support and capacity to implement means that progress towards implementation is uncertain. So what happens when all of these things take place? We don't have implementation. Those that can't access or do not have access to services continue not to have access to services. So we need to find ways in which we can address some of these concerns. Concluding statement. We need to do this in an effective manner. We need to have coherence in the way in which we do it, and we need people to listen to each other. Thank you.
Thank you very much for the insightful presentation, giving a great detailed overview on some of the concerns and questions that we have. No, Visha, you will still be here. There are some questions.
You're not going to get anything.
Yeah, I want to say.
Can you mute, please? Okay. Yeah. So we on the chat there were 2 comments, and I know that we have passed time by some 4 minutes. So I hope people will still hang around for some few more minutes so that we can just conclude our session. Percy, are you there? You had written about issues around accountability versus what? I think I wrote it somewhere. Accountability versus oversight. Would you like to shed more light on that so that Visha can respond to that? Percy, are you there?
Okay, thank you. Is it Dr. Julia?
Yes, Dr. Juliet speaking.
Hi, thank you. This is Percy Dahms. My comment there was just to say there's a difference between accountability and oversight. And because health is such a big issue in this country, it's a fundamental right. We should do a little bit better. And oversight is more taking that responsibility to the center of government, where you will monitor the outcomes at a population level rather than just depending on accountability of the minister for the outcomes. And in many countries, the regulatory function are separate from the oversight, especially for that reason because accountability is still with the regulator and with the ministries, but the oversight is more central to the constitution and closer to parliament, who has overall responsibility for the whole country. For example, you have many institutions like that provide oversight in various areas.
Okay. Thanks so much for your views. What is your comment, Vishu, in that regard?
I agree. I think that the biggest challenge we have currently is that if you look at the NHI environment, you don't have a regulator and you don't have a mechanism like that. So it is important to look at both elements. I'm not disputing that. I think it's a fair comment to make. I think we must also make sure that we identify what accountability means, not just at a national level, but at an individual level in terms of how we engage in the system.
Thank you so much. Our last question is from Desmond. It says, from an economist point of view, we seem to know what to do in terms of accountability. However, there seems to be a reluctance to do exactly that. What are the recommendations that could change the lack of responsiveness? Over to you, Vishal.
I don't think I have an answer for that one. I think it's a difficult question. I think that when we look at the issues that we've seen around lack of accountability, the lack of transparency, and you know, where we've seen egregious corruption taking place, and no one actually being held accountable for them, it creates doubt for amongst all of us in terms of the system. So I think we need to start looking first at ourselves and around ourselves. We spoke about this today in the class. I think that one of the biggest issues is you can't look at somebody else for that. Lead by example, no matter what level of the system you are in, and refuse to participate in anything that is that doesn't or sort of that deviates from your moral compass, your ethical compass, wherever you need to be. If we don't do that and we look the other way, then the system will continue as is. And I think that's unfortunately where we are. People have become agnostic towards it. Rather than being agnostic, and sometimes we don't have everything in our powers to do it. And by no means will I ever suggest that people must put themselves in harm's way or to point some of these things out. But let's start amongst ourselves and the teams that we work in, and ensure that we do things properly, and amongst ourselves as colleagues, that we encourage other colleagues to actually do the same thing, and start somewhere. Waiting for legislation to be put in place is the wrong way to do it. This is something that all of us are taught that's wrong to do. So why do we do it? If we can ourselves not do certain things, it makes sense. We are all guilty of traffic offenses. Why don't we actually drive in a way that doesn't break the law? So we're not adhering to some of the social values, and those social values then pass on into our professional lives. So I think that's one of the main reasons, is because regardless of regulatory frameworks, the social value is no longer there. It doesn't make people are not really interested. They don't bother anymore. Some people don't even bother to hide their corruption. Yeah.
Okay, thank you very much, Vishal, for such a comprehensive presentation and very insightful indeed. And for your information, Vishal has been around in our division this week. He was teaching on our PG Deep program. We are running a module on leadership and financial leadership and governance. And he has really been instrumental, in imparting knowledge and inspiring the managers in the program. In this program, usually it's a PG Deep in healthcare management. So the participants are managers. So he has been around, and this session was part of our module. So we thought we needed to invite more, because the more the merrier, and also realizing that this topic is quite topical and critical. So thank you so much, and thanks everyone for attending. Online there is a link where if you need CPD points, you can complete the CPD points through a link. Just check in the chat box. There is that, but otherwise, thank you, and we did appreciate your presence and participation. Thank you so much. Bye-bye.